Welcome to this episode. Today we're diving into the clinical consequences of congenital heart disease in children, focusing on two major complications, heart failure and hypoxemia. It's a complex topic, but we'll break down the pathophysiology, clinical signs, diagnostics, and therapeutic strategies, including the nuances of pharmacologic and nursing care. Chloe, it's a dense subject, but so critical for pediatric cardiology.
Absolutely, Liam. It's fascinating how heart failure in children differs so much from adults, especially since structural abnormalities like septal defects are the main culprits here, rather than ischemic disease. That sets the stage for a very different clinical picture and management approach.
Right, and that's a key point. In kids, heart failure often results from volume and pressure overload due to these congenital defects, which increase blood volume inside the heart chambers. But it's not just that. Myocardial failure from cardiomyopathy, arrhythmias, or electrolyte imbalances can also impair ventricular contractility. Plus, excessive metabolic demands like sepsis or severe anemia can tip a normal heart into failure.
Yeah, and when we talk about heart failure in children, it's important to distinguish right-sided from left-sided failure. Even though pure forms are rare because the two sides are so interdependent, the right ventricle's failure to pump blood into the pulmonary artery leads to increased pressure in the right atrium and systemic venous system, causing hepatosplenomegaly and peripheral edema.
Exactly. And on the flip side, left-sided failure means the left ventricle can't effectively pump blood into systemic circulation, so pressure backs up into the left atrium and pulmonary veins. That results in pulmonary congestion, elevated pulmonary pressures, and pulmonary edema. But as you said, in children, failure on one side almost always affects the other because the heart functions as a tightly coupled two-pump system.
That interdependence is crucial clinically. If one chamber fails, the other compensates initially, but eventually both suffer. And if the underlying defect isn't corrected, the heart muscle sustains damage, and compensatory mechanisms fail, leading to inadequate cardiac output.
And that sets off a vicious cycle. Reduced renal perfusion triggers sodium and water retention, which increases fluid overload, further stressing the heart and worsening congestion in both pulmonary and systemic circulations.
Right, and clinically, we see this manifest in three main groups of signs and symptoms: impaired myocardial function, pulmonary congestion, and systemic venous congestion. The impaired myocardial function group includes tachycardia, inappropriate sweating, fatigue, weakness, restlessness, anorexia, pale and cool extremities, weak pulses, low blood pressure, gallop rhythm, and cardiomegaly.
The pulmonary congestion signs are tachypnea, dyspnea, retractions especially in infants, nasal flaring, exercise intolerance, orthopnea, cough, hoarseness, cyanosis, wheezing, and grunting. And systemic venous congestion shows up as weight gain from fluid retention, hepatomegaly, peripheral edema, particularly periorbital ascites, and neck vein distension.
The variability in presentation depends on the timing and cause of heart failure, which makes clinical assessment challenging. Diagnosis relies heavily on these clinical signs, but imaging is essential too. Chest X-rays typically show cardiomegaly and increased pulmonary blood flow, while ECGs may reveal ventricular hypertrophy, arrhythmias, or low voltages.
And echocardiography is the cornerstone for identifying the underlying defect or ventricular dysfunction. It's indispensable for guiding management.
Speaking of management, the goals are pretty clear. Improve cardiac contractility, reduce afterload, remove excess fluid and sodium to decrease preload, decrease cardiac metabolic demands, and improve tissue oxygenation while reducing oxygen consumption.
Pharmacologically, digitalis glycosides like digoxin remain a mainstay. They improve myocardial contractility and efficiency, increasing cardiac output, reducing heart size and venous pressure, and relieving edema. But dosing is tricky in pediatrics, usually calculated in micrograms, and toxicity is a real concern.
Yes, digoxin's narrow therapeutic window means we have to be vigilant. Signs of toxicity include nausea, vomiting, anorexia, bradycardia, and dysrhythmias. Checking the apical pulse before administration is critical, with withholding criteria varying by age, usually below 90 to 110 beats per minute in infants and young children, and below 70 in older kids.
And potassium balance plays a huge role here. Hypokalemia enhances digoxin's effects and increases toxicity risk, while hyperkalemia diminishes its efficacy. So monitoring serum potassium is essential.
That's why ACE inhibitors are also important. They reduce afterload by blocking the conversion of angiotensin I to II, causing vasodilation, lowering pulmonary and systemic vascular resistance, and decreasing aldosterone secretion. Common agents like captopril, enalapril, and lisinopril are used. But we have to watch for hypotension, cough, and renal dysfunction.
Beta blockers, particularly carvedilol, are used selectively in children. They block alpha and beta adrenergic receptors, reducing heart rate, blood pressure, and causing vasodilation. Though less common than in adults, they're gaining traction in pediatric chronic heart failure.
Diuretics are the mainstay for removing excess fluid and sodium. Furosemide is the drug of choice in severe heart failure, but causes potassium and chloride loss, so hypokalemia is a concern, especially with digoxin therapy.
Chlorothiazide is less frequently used, but also causes hypokalemia and acidosis at high doses. Spironolactone is a potassium-sparing diuretic often combined with others, but it takes several days to reach full effect. Importantly, potassium supplements should be avoided with spironolactone to prevent hyperkalemia.
There's also emerging use of cardiac resynchronization therapy with biventricular pacing in pediatrics, especially for single ventricle physiology. It's promising for improving cardiac function alongside pharmacologic therapy.
Nursing care is equally critical. Administering digoxin requires precise dosing and monitoring for toxicity. The apical pulse must be checked for a full minute, and any significant drop from previous readings warrants withholding the dose and notifying the provider.
And afterload reduction with ACE inhibitors means careful blood pressure monitoring before and after doses, watching for hypotension, and assessing renal function and electrolytes, especially when multiple diuretics are involved.
Decreasing cardiac demands involves minimizing metabolic stress, providing a neutral thermal environment to prevent cold stress, treating infections promptly, reducing respiratory effort by positioning the child in semi-Fowler, sedating irritable children if needed, and ensuring adequate rest with minimal environmental stimuli.
Oxygen therapy with cool, humidified oxygen supports tissue oxygenation, especially in pulmonary edema or increased pulmonary vascular resistance. Nasal cannulas are ideal for long-term use since they allow mobility and feeding, but humidity must be carefully regulated to avoid chilling.
Fluid restriction is rarely necessary in infants because feeding difficulties usually limit intake, but it may be needed acutely. Sodium restriction is less common in children due to concerns about appetite and growth.
Nutritional support is a major nursing challenge. Infants with heart failure have increased metabolic demands but limited feeding tolerance. Strategies include smaller, more frequent feedings, high-calorie formulas, and gavage feeding if necessary. Breastfeeding parents can be encouraged to fortify expressed milk.
Supporting the family emotionally and educating them on medication administration, signs of worsening heart failure, and care routines is vital. Stress increases cardiac workload, so reducing anxiety through clear communication and reassurance is part of comprehensive care.
Shifting gears to hypoxemia and cyanosis, these occur when arterial oxygen tension and saturation fall below normal. Cyanosis usually becomes apparent when saturation drops below 80 to 85%, but its detection is subjective and influenced by skin pigmentation, lighting, and hemoglobin levels.
That's an important nuance. Anemia can mask cyanosis despite hypoxemia because there's insufficient hemoglobin to produce the blue color, while polycythemia can exaggerate cyanosis even with near normal oxygen levels.
Cyanotic heart defects allow desaturated venous blood to bypass the lungs and enter systemic circulation, causing hypoxemia. Mild hypoxemia may only show cyanosis with near normal growth, but severe hypoxemia leads to fatigue, poor weight gain, tachypnea, dyspnea, and poor perfusion.
Chronic hypoxemia triggers polycythemia, an increase in red blood cells to compensate, and clubbing, which is thickening and flattening of the fingertips, reflecting long-term tissue hypoxia.
Then there are hypercyanotic or TET spells, often seen in infants with tetralogy of Fallot or similar defects. These are sudden episodes of profound cyanosis and rapid breathing caused by infundibular spasm, reducing pulmonary blood flow, and increasing right-to-left shunting.
They typically occur in the first year of life, often in the morning or after feeding, crying, or stress. These spells are emergencies because cerebral hypoxia can cause brain injury or death if not promptly treated.
The classic bedside intervention is placing the infant in the knee-chest position. This increases systemic vascular resistance, reducing venous return from the legs and diverting more blood into the pulmonary artery.
Along with that, administering 100% blow-by oxygen, giving morphine subcutaneously or IV to reduce infundibular spasm, and providing IV fluids for volume expansion if needed. Repeated morphine doses may be necessary.
These spells indicate the urgent need for surgical correction if possible. For infants not amenable to repair, surgical shunts like the modified Blalock-Taussig, Sano modification, central shunt, or bidirectional Glenn are used to augment pulmonary blood flow.
Each shunt has specific benefits and risks. For example, the modified Blalock-Taussig shunt connects the subclavian artery to the pulmonary artery, but can cause excessive blood flow requiring diuretics and carries thrombosis risk, so aspirin is often prescribed postoperatively.
The Sano modification connects the right ventricle to the pulmonary artery, preventing diastolic runoff and improving coronary perfusion, often used in the Norwood procedure. The bidirectional Glenn shunt connects the superior vena cava to the right pulmonary artery, relieving cyanosis and volume overload but carries embolic risks.
Hydration is critical in cyanotic infants to keep hematocrit and blood viscosity within safe limits, reducing stroke risk. Fever must be evaluated promptly due to the risk of bacterial endocarditis, and anemia monitored closely with iron supplementation or transfusion as needed.
Respiratory infections worsen hypoxemia, so aggressive pulmonary hygiene, antibiotics or antivirals, and supplemental oxygen are essential. Oxygen is a medication and must be used judiciously, especially in complex hemodynamics where it can sometimes be harmful.
Nursing care also involves preventing dehydration, monitoring fluid balance and weight, and educating families about cyanosis, hypoxemia, and managing hypercyanotic spells. Safety is paramount. Due to right-to-left shunting, air embolism risk is high, so IV lines must be air-free with filters and secure connections.
That's a critical safety point. Even small air bubbles can cause cerebral embolism in these patients, so meticulous line management is non-negotiable.
To wrap up, pediatric heart failure primarily results from structural defects causing volume and pressure overload, with complex interdependence of right and left heart function. Clinical signs cluster into myocardial dysfunction, pulmonary congestion, and systemic venous congestion, requiring comprehensive assessment.
Management combines pharmacologic agents like digoxin, ACE inhibitors, beta blockers, and diuretics, with supportive nursing care and surgical interventions. Hypoxemia and cyanosis reflect shunting of desaturated blood, with chronic hypoxemia leading to polycythemia and clubbing.
Hypercyanotic spells are acute emergencies needing prompt intervention, and prostaglandin E1 and surgical shunts are critical in managing ductus-dependent and cyanotic lesions. Nursing care is multifaceted, focusing on medication safety, nutrition, respiratory support, hydration, infection prevention, and family education.
It's a complex interplay of pathophysiology and care, but understanding these nuances is essential for optimizing outcomes in these vulnerable children.
Absolutely. Thanks for exploring this with me today.
Thank you. It's been a thorough and insightful discussion.